Good morning and welcome to this presentation for Dental XP. Today we will focus on the key factors for aesthetics on implant-supported restorations. This is kind of continuation of what have been introduced by Dr. Gobato in the part 1 of this lecture, focusing on the surgical aspects. In the next 40 minutes we will focus on the key restorative factors for aesthetics on implant-supported restorations. And as you can see on this table, we have plenty of aspects that we should focus and we should consider when we are treating implants on the aesthetic zone. And in our opinion, we have to really consider 3 important prosthetic keys. And these 3 factors will be present in all the cases that we will discuss together in the next 40 minutes. First of all, we have a need for a customized soft tissue management that has to start in the moment we extract the tooth with a 3-dimensional ovate Pontic, with an implant-supported provisional restoration that has to customize the soft tissue around the implant, and with the profile of this prosthesis that has to be normally under-contoured on the facial aspects. We need to have then a customized impression technique that needs to transfer all the informations from the provisional restoration into the definitive one. Last but not least, we need to customize our definitive restorations, taking advantages of all the materials that we do have today and with all the digital technology that definitely is helping us a lot. So let's start looking at one first case in which we have to make the first point. When Francesco presented to our attention, he had a problem because he had a car accident and he lost the 2 central incisors. The key starting point is that we have to know exactly where to position our implant. So implant position is the starting point of all the treatment. And we have plenty of literature that is telling us what to do and where to place our implant in relation to the bone and to the adjacent existing dentition. In particular, this paper from Daniel Buser explained important information describing 2 different zones, a danger zone and a comfort zone where we can position and place our dental implants. I just want to give you 3 important numbers that are 1.5 millimeters, that is the distance that we need to have between an implant and the adjacent dentition. And this number has to be double if we consider implant to implant distance. Then we need to consider 2 as 2 millimeters, that is the amount of bone that we need to have on the facial part of our implant. And last, we have to consider the number 3 as 3 millimeters as the depth we have to position our implants in relation to the expector or to the planned gingival margin. But what is really important to me is that the implants need to be positioned simultaneously according to the bone, but also to the planned prosthesis. So we need to consider the final outcome in terms of aesthetics and in terms of function. And digital technology today is really helping us because it's allowing us to position our implant in a way that is bone-driven from one side and prosthetic-driven from the other side. And we can simultaneously decide where to place our implant in relation to the remaining amount of bone and to the planned tooth position. And again, digital technology is really helping us because, as you can see in this video, we can plan the position of the implant and utilize surgical stents to position flapless our implant, and we can deliver to our patients immediately the same day of the surgery the definitive customized abutment and proceed with a provisionalization that in this particular case happened to be fabricated with titanium abutment gold U and with cemented type provisional restoration. That is immediately provisionalized, but we don't consider this as immediate loading since we don't load this implant for the first couple of months. And this is the final result with the nice aesthetics and the good integration between the implants and the peri-implant bone. Something that is really critical to us is to achieve and have in all the implant-supported restoration a good amount of soft tissue around our implant. And this is introducing the conversation into the second aspect of this presentation, that is the consideration of the amount of soft tissue that we need to have around the implant. We all know that on natural dentition, if we have, or also if we don't have prosthesis on the teeth, we prefer to have a thick tissue, as you can see on the left picture, compared to a thin tissue. And on implant-supported restoration, the situation is very similar, because we have much more instability of the soft tissue, we have much more instability of the hard tissue, and we have much more challenging aesthetic result if we are dealing with thin tissue. We published a few years ago with our research team in the University of Padua an interesting paper that was considering the aesthetic outcome of the peri-implant soft tissue in terms of color, in terms of shade. And we will talk about this later on in the presentation, but something that was extremely interesting in our finding is that we had a population that was made up of 55% of thin tissue biotype, but the same exact population which was having implants on the aesthetic zone were having 87% of thick tissue in the same type of population. What does it mean? That the positioning of an implant is for us an opportunity to modify a thin tissue into a much thicker one. How? Placing the implant in the correct position, as we described a few minutes ago, increasing the thickness of the soft tissue surgically and maintaining the thickness of the soft tissue prosthetically with proper emergence profile. So from now on, we will start discussing all those steps, especially prosthetic step, that we need to follow and we need to do from the moment we extract the tooth till the moment we deliver the final restorations. We need to increase, and this Luca of course explained in his presentation, definitely the amount of soft tissue in the moment of the extraction, in the moment of implant stage 2, in order to helping the work of the prosthodontist, or of the restorative dentistry, who just need to manage the soft tissue with the profile of the prosthesis. A few years ago, a nice paper was published in the International Journal of Periodontics and Restorative Dentistry, and in this paper were described two different areas. The first area was the subcritical area, the one that in the picture is colored with orange color. And then there is a critical area, that is the area that is much closer to the gingival margin. And it is extremely important for us to have a proper profile of our prosthesis, and our profile, as you can see on this picture, needs to be under contoured on the facial profile and becoming more flat and almost convex in the interproximal and palatal side. This in order to maintain a thicker amount, as you can see on the picture, of soft tissue on the facial aspect of the implants. So let's jump on a few cases that describes our approach to this type of restorations. Marilena was one of our patients who presented to our attention a few years ago. Was December 2007, and Marilena was having a problem because the central incisor fractured. Of course, she had a huge metal post, cast post and core, and most probably not much ferrule effect. And of course, these are potential concause of the problem that happened, and the problem now is that this fractured tooth needs to be extracted. And of course, it's not an issue of this presentation, but Luca in his presentation explained it properly, that we need to manage properly the surgical aspect of the case by an atraumatic extraction of the tooth. In this particular case, we proceeded with an immediate implant placement, and as you can see on the small picture on the top of the screen, with an connective tissue graft to cover the implant. And what is extremely important from a prosthetic perspective is that right after the insertion of the implant and the grafting of the connective tissue, we need to proceed with our prosthetic first step, that is the insertion of an ovate pontic, in this case a temporary Maryland bridge. It means a fixed provisional restoration. We need to have a fixed provisional restoration in these cases because that's the only way we can really manage the soft tissue and get advantage of the swelling of the tissue right after the surgery and in the first 3-4 days of the surgery in order to achieve a proper aesthetic and also a proper comfort for the patient during the first 2-3 months of treatment. And this is what we want to see below the ovate pontic. We cement in a definitive way the Maryland bridge that is prepared with no tooth preparation, and we remove the Maryland bridge only 4 months after the implant placement. And we'll keep it in its position for all the time of the osseointegration. The shape of the ovate pontic is not special. It's something that has been described in the books since many years. In the crown and bridge textbooks, we start talking about ovate pontic, and what we need to take care is that, as you can see from the blue arrow, we don't want to give too much pressure on the facial aspect of the ovate pontic, but we just want to support the tissue right more palatally compared to the blue arrow. And the second important aspect is that these ovate pontics need to give enough pressure in the spot of the 2 green arrow in order to support the interproximal papilla. We all know the interproximal papilla is maintained by the interproximal bone peak, in this particular case by the interproximal bone mesial to tooth number 9 and mesial to tooth number 7. But papilla act in the same way of a water bag. If we compress the papilla from its more apical part, we will hold the tip of the papilla more coronally, as you can see later on. Last but not least, we need to complete our ovate pontic also on the palatal aspect with a 3-dimensional shape in order to give the patients from day one an adequate comfort of the restoration and to avoid food impaction on the area. The only difference we have comparing to the ovate pontic on natural dentition without an implant underneath is that we actually are going a little bit less deep on the alveolus and a little bit less compression is given to the connective tissue graft because this is planned with only about 1 to 1.5 millimeter depth compared to the gingival margin. As you can see from this picture, after the 4-month time of the osseointegration of the implant, the tissue keep maturing and the interproximal papilla are held in an adequate position, and the facial soft tissue are also providing the patient with an adequate aesthetic outcome during all the time of implant osseointegration. Normally, what we try to do is to index the implant at the stage 1. It means that right after the implant insertion, we take an immediate impression of the implant and we give the time to the dental technician to fabricate a screw-retained acrylic or composite, if we prefer, provisional restoration that is prepared during the time of osseointegration and then is delivered to the patient at the implant stage 2 that happen to be 4 months after the implant insertion. What we have to do in this case, as you can see on the left side of your screen, we want to play with the profile of the implant. We want to have, as mentioned, an under-contoured emergence profile, but we want to increase somehow the convexity on the most coronal portion of the subgingival tissue in order to achieve a same scalloping on tooth number 8 and on tooth number 9, as you can see on this picture. Central incisor doesn't have any issue besides making our restoration the exact copy of the contralateral tooth. You can see some blanching on the picture that disappear a few minutes after the insertion of the provisional, and what we are expecting in the month after the insertion of the provisional is that the facial soft tissue might move slightly more apically, with the movement that can be more extended if we are dealing with multiple implants, but this movement can be much less evident if we are having a single implant due to the bridging effect that happens from the tissue of the adjacent dentition. The opposite thing is happening on the interproximal aspect of the implant, in which we can see that the tissue, little by little, is moving more coronally, as you can see on this picture. In fact, a few months after the delivery of our provisional restoration, we can see that little by little the interproximal black triangle are becoming fulfilled by soft tissue, because this interproximal soft tissue, if the interproximal bone peak is present and if the adequate support is given by the interproximal implant emergence profile, can have a good extension on a vertical condition. After waiting a period of about 3 months, we move to the following step, that is the impression technique. And it's extremely important that all the effort that we made on the previous month is transferred to our dental technicians. So we need to have a customized impression techniques that deliver to the dental technician the exact shape of the provisional restoration into the final restoration. As you can see, definitely we remove our provisional restoration, and with some silicone, putty silicone, we shape and duplicate the shape of the provisional restorations into a customized impression coping. So when we reinsert our impression coping into our provisional, into our intraoral condition, it's going to be the flowable composite that we utilized in this particular situation that give the shape information to the dental technician and not the polyether material. Because as you can see on the picture on the right side of the screen, the most apical portion of the customized abutment is defining the shape of the peri-implant soft tissue. If you don't do this, what can definitely happen is that the soft tissue collapse over the implant and we do not transfer these precise informations into our master casts. And this is the final restoration, that is happens to be a zirconia ceramic restoration delivered about 9 months after the extraction of the tooth, with the following of 3 different steps: the extraction of the tooth and the insertion of the ovate pontic, the stage 2 of the implant and the insertion of a screw retain provisional restorations, and finally, through the customized impressions, the insertion of a customized provisional restoration. We will talk about this in a few minutes. This is the post-op radiographic combine at 5 years. It's extremely important that when we approach cases of single implant in the aesthetic zone, we complete 100% our diagnosis. The time that we spend to do a proper diagnosis is always well spent. And as you can see, we published a few months ago an interesting paper in the Quintessence International Journal, in which basically we analyzed single implant supported restorations on central incisor in relation to the crown shape of the existing dentition. And what we noticed, that if we are treating a central incisor with an implant supported restoration, is much easier our job if we are dealing with square shaped teeth, as happened in the previous case of Marilena. In fact, in these cases, most of the time we can achieve a good aesthetic result in terms of symmetry, presence of papilla, and final aesthetic outcome with only treating the central incisor. In about 10% of the cases, we had the need to work also on the adjacent tooth in order to achieve a good result. On the other side, as you can see on the left side of the screen, is much more difficult our job if we are dealing with triangular teeth. This because it's much more difficult to achieve a good symmetry between our implant-supported restoration and the contralateral tooth. It means between tooth number 8 and tooth number 9. In these particular cases, most of the time we have really the need to work also on the adjacent dentition. As you can see on the case of Isabella, Isabella is completely different from what happened before to Marilena. In fact, we are dealing with triangular shaped teeth. Tooth number 8 as you can see from the arrow, has already been extracted, and tooth number 9 will need a treatment as well, because if we just work on tooth number 8 and we don't work on tooth number 9, it will be impossible for us to achieve a nice aesthetic result with a nice and adequate symmetry between tooth number 8 and tooth number 9, between the two central incisors. It's interesting to see and to view in this picture that in fact if we insert a triangular shaped tooth trying to keep an adequate symmetry between the two central incisors, black triangle will still be present. That's why in these particular cases we had the need to insert also and to apply also porcelain laminate veneers on tooth number 9 in order to achieve a nice and adequate symmetry, as you can see on this slide, between the two central incisors. Basically, we change a triangular shape into a square shape teeth, but we achieved, comparing to the starting point, a good and natural symmetry in the final aesthetic result. Things are a little bit less complicated if we are dealing, like in this specific case, with a shape of the teeth that is something in between square and triangular, some shape that we consider and that has been considered in the literature as square tapered shape. In fact, in this particular case, only an additional restoration was fabricated on tooth number 9, as you can see on this picture, without any tooth preparation. Let's go and take a look into these specific cases. Nothing is different from what happened before because the tooth was extracted atraumatically. The implant was inserted as an immediate implant immediately after the extraction of the tooth. An ovate pontic was delivered right after the insertion of a connective tissue graft. Few months after, it means 4 months after, a screw retain provisional restoration have been delivered with an under-contoured profile, as you can see on this picture, and the provisional composite additional laminate veneer was delivered on tooth number 9. And this is the provisional result that already completely changed significantly the shape and the shade of the existing teeth. Again, as we did in the previous case, a customized impression with customized impression copying was taken in order to transfer to the dental technician the exact shape of our provisional restorations, and this is the delivery of the definitive zirconia abutment and of the cemented type zirconia crown. This is the bisque train, and at the bisque train we just keep going with the pickup impression of the crown and with the definitive impression of the additional porcelain laminate veneer. Again, no tooth preparation was performed, and this is the delivery of the final result. You can see on the left side of the screen a porcelain laminate veneers that is only placed without any cement, just with some water or some saliva on tooth number 9, and thanks to the help of great dental technologists, we can achieve a nice final aesthetic outcome that is helped by material. Feldspathic porcelain, in fact, is extremely translucent and can take the shade from the underlying tooth structure. And this is the final aesthetic result that definitely is giving to this particular patient a good aesthetic outcome in terms of natural result with a nice symmetry between the two central incisors. Let's talk a little bit about the geometry of the customized abutment, because this is an extremely interesting aspect that we want to consider. Customized abutments are normally fabricated in a customized way with a light chamfer preparation, not deep but light, and the location of the finishing line is extremely important. We normally maintain the location of the finishing line about 1 millimeter subgingival on the facial aspect, about 0.75 millimeters subgingival at the interproximal level, and we want to maintain the palatal margin at the gingival level. It means equigingival. In this way, we can check the fitting of our prosthesis without particular problem. We can remove without problems the excessive cement during the cementation, and we can achieve a nice and adequate aesthetic outcome. It's extremely important to talk about material also when we are treating these cases. And a lot of materials are today in the market for us to give a good result. But remember, material is important, but much more important is the shape of this restoration. Just giving a few information about materials, we published this paper we mentioned also at the beginning of the presentation in the clinical oral implant research in 2001, in which we compare the final aesthetic outcome of the soft tissue in terms of shade on the facial aspect of the implant. And we tried different type of abutment with different color: zirconium, white, tooth shape; titanium, gray; and gold, yellowish. And what is interesting that we find in this paper is that titanium is giving us the worst aesthetic outcome when we are treating implant-supported restoration in terms of shade of the peri-implant soft tissue. But on the other side, gold abutments with yellowish color and zirconium abutment has not much difference. So if we have to choose our material for the customized abutment following the aesthetic guidance, we don't want to select titanium, but we prefer to select gold or zirconium. If instead we want to look at the biological answer from the soft tissue, there are today different histological studies that are guiding us towards titanium and zirconium, because we have increased stability of the peri-implant soft tissue. But clinically, this nice paper from our friend Paolo Vicolo is telling us that there is not much clinical difference between gold and titanium. So my conclusion is that basically we can choose titanium and zirconia. We most probably will have a better histological answer, a biological answer from the tissue. These are histological studies performed on animals, so not on the human, but clinically this difference is not so significant. But what I was saying is more important than the material is the shape of our restoration. And what I really want to stress today is the importance of having under-contoured emergence profile on the facial aspect of the implant. Technology anyway is helping us a lot, helping our patients, and there is a big request today for all ceramic restoration, the so-called metal-free restorations, and we have the need to follow the request of our patients. So many times in the aesthetic zone we want to have all ceramic restorations. What I don't recommend to utilize is the full all ceramic customized abutment, because we might have issues in terms of resistance, medium, long term, but also short term, and also in terms of accuracy. What we normally utilize are customized abutment fabricated with zirconium or fabricated with lithium disilicate that are cemented on a titanium connector that is giving us precision and also the adequate strength. Let's look at two different cases in which we made different selection of these two types of abutments. This first case is the case of Luigi, who presented to our attention to improve his smile. And of course, we have some problems in his mouth in terms of shade and in terms of shade of natural dentition. But we have also an issue that is forcing us to place a single implant supported restoration on tooth number 7. So we insert a provisional restoration on tooth number 6, 7, 8, and 9. Is an acrylic provisional restoration. The treatment plan is involving 3 crowns on tooth number 6, on tooth number 8, and on tooth number 9. We extract tooth number 7, and we start with the first step that we saw also in the previous cases. It means the customized soft tissue management of the soft tissue over the implant with the ovate pontic. We wait 4 months, we perform the implant stage 2, you can see the provisional that is getting worn during the period of osseointegration, and in this moment we connect our implant with our provisional restoration, customizing the management of the soft tissue over the implant. So we have the peri-implant profile that is becoming important at the provisional restoration stage. We leave this provisional for about 2 to 3 months in order to have a good maturation of the tissue, and then we go to the next step. It means the customized final impression, in which we transfer to the dental technician the information of the mouth in order to have these informations in the definitive master cast. And what you can see on this case is that we have extremely discolored teeth. So this is not a good case for selecting a translucent material such as lithium disilicate. That's why in this case we selected for the teeth zirconium. That's why for these cases we select for the abutment of the crown a zirconium type of restoration. So we are at the trying stage in which we try the implant-supported restoration and also the coping, zirconia coping of the crown, and this is delivery of the final implant-supported restoration and of the final 3 single all-ceramic zirconium ceramic type of restoration on the adjacent dentition. Similar situation but different choices happens for Nicoletta, who was used to be a dental assistant, but now is a 44-year-old patient who present to our attention asking for 3 porcelain laminate veneers on tooth number 7, 8, and 9. Of course, this discoloration has a cause, so at the radiographic examination we realize that we have some problems. We cannot solve this case with 3 veneers, but we have to solve this case with 2 all-ceramic crowns on tooth number 8 and 9, but unfortunately tooth number 7 is hopeless. So we need to extract this tooth and to go ahead with an implant-supported restoration on tooth number 7. The steps, one more time, are exactly the same steps that we saw in the previous case. It means that we go ahead with the insertion of a provisional restoration on tooth number 8 and tooth number 9 with the cantilever ovate pontic on tooth number 7 that is inserted right after the extraction of the tooth and the insertion of the implant and the grafting of the soft tissue. Our ovate pontic is managing the soft tissue for about 4 months. As you can see, the tissue is healing in the proper way around the ovate pontic, and the patient is having a proper aesthetic and the proper function, a good comfort throughout all the time of the treatment. This is the condition before the stage 2 of the implant. As you can see, nice tooth color restoration. The 2 natural teeth has been endodontically treated, and you can see a nice management of the soft tissue with the ovate pontic. Implant stage 2 is performed. The implant is connected to our existing provisional restoration, and a nice peri-implant profile start managing for about 2-3 months the peri-implant soft tissue. We go ahead to the next step one more time, customize definitive impression with single core technique on tooth number 8 and 9, and customize the impression coping, as you can see on this picture, on tooth, actually on implant number 7. And one more time is the provisional restoration shape that is transferred to the definitive restoration through the utilization of customized impression coping. And in this case we have a nice color of the abutment teeth. That is the ideal condition for utilizing a lithium disilicate restoration, and that's why we selected a lithium disilicate abutment, and here is the insertion of the abutment, and lithium disilicate crowns both on the 2 teeth and on the implant. And this is the final aesthetic outcome and the final smile of the patient that is showing a good amount of soft tissue, stable on the facial aspect of the implant, and a good and adequate natural aesthetic result, especially important in a patient like this in which we have a high lip linet smile. So one last aspect that I want to speak about before the end of this presentation is the timing of the positioning of the implant abutment. Because if you look at these cases, we insert the provisional abutment at implant stage 2, in those cases in which we index the implant during the implant stage 1, and we insert the definitive abutment at the delivery of our restoration. But unfortunately, we had to change the implant abutment plenty of times before the end result of our restoration. In all these cases, about 6, 7, or 8 times before delivering the final result. And we have some literature that is forcing us to the concept one abutment at one time. It means to deliver the definitive abutment at the earliest possible stage, because this procedure of removing and reinserting the abutment can create some damage to the peri-implant soft tissue and hard tissue. So technologies helped us in these cases, the case of Marco, trying to help us in a reduced number of time of insertion of the abutment. We tried, it means to have a one abutment, one time concept applied in this specific case. Marco had a trauma playing soccer, and he missed he presented to our attention with a missing central incisor and with a malposition tooth number 8, as you can clearly see on this radiographic examination. Tooth number 8 was repositioned in its alveolus and later on endodontically treated, splintered for a while, but tooth number 9, that was fractured below the soft tissue level, but below also the bone level, was extracted and an implant was positioned. In this case, we had to open a flap and to perform a surgery with flap, but what is interesting is that we indexed the implant during the surgical step. We prefer to utilize silicone material, and there are today on the market also many radio-opaque material that can be detected eventually on the radiographic examination after the impression. But again, in these cases, we have an ovate pontic ready after the surgical procedure that is inserted immediately after the surgical procedure, managing the soft tissue during the time of implant osseointegration. And we utilize the concept of one abutment one time because we kind of try to predict the final position of our margin, of our gingival margin, through a proper and adequate and very careful wax up, as you can see on these cases, and the information of the wax up are then manually transferred to the fabrication of a customized abutment and then digitally transferred to the fabrication of a definitive zirconium abutment with a titanium connector, as we saw before. So this abutment comes back from the dental laboratory and is inserted exactly in the day of implant stage 2 on the implant and screwed definitively to 20 Newton in this particular case. As you can see, the profile is under contour, as well as under contour is the profile of the titanium connector. This is only 2 weeks after implant stage 2. We have a cemented type restoration with all the concept that we saw before of the screw retain type of restoration, but the difference between this case and the previous cases is that in these particular cases we delivered immediately the definitive abutment and we started working at the abutment level, not at the tooth level. What is interesting that together with our abutment, the dental laboratory already fabricated also our definitive coping, zirconia coping in this case, for the definitive restoration that is placed 4 months after the insertion of the provisional, times that we dedicate to the tissue maturation, is placed onto the abutment in order to have an abutment level impression. So we don't work anymore at the implant level in this case, but we do work at the abutment level just with the pickup impression. Much more effective, we spend less time to do this procedure, much less pain is created to the patient, we don't need to give any anesthesia to remove or insert the component, and much more biologically correct to the stability of the peri-implant soft tissue. We do a pickup impression, and all the difficulties that we normally have when we are trying to achieve a great result in a single implant supported restoration in terms of shape, but especially in terms of shape, are managed in a much easier and faster way just at the abutment level without having the need to screw and unscrew more than once the abutment that we have delivered at day 1. And this is the delivery of the final restoration. The abutment is torqued down and the crown is cemented. What we are trying to do today at this stage, we are cementing this crown temporarily, we are checking that everything is stable, and at this moment we are changing our restoration from a cement type of restoration, you can see all the advantages of the cement type restoration on the left side, into a screw retain type of restoration. Today we have a lot of articles that are telling us that there might be some issues if we leave some cement trapped underneath the soft tissue, and it's much more difficult if we deliver our abutment at day 1 to achieve a margin level that is positioned immediately after, immediately subgingival. Many times we end up a little bit more subgingival, like in this case on the interproximal level. So what we want to do in this specific case, due to biologic issues, in order to avoid the risk to leave some cement subgingival, we removed a second time, actually a first time, the abutment. We cement our restoration that has already been fabricated with the hole extraorally. We clean up, as you can see, all the cement that might remain in the interface between the abutment and the crown, and then at the end we transform our cemented type of restoration into a screw retain type of restoration, as you can see on this picture on the left side of the screen, in which we are inserting for a second time the definitive abutment, this time all one together with the crown. And then the crown is delivered, and from a cemented type of restoration we are having a screw retain type of restoration. And this is the final aesthetic outcome. In these particular cases, all the steps that have been utilized in the previous case have been followed. All the fundamental concept that we saw at the beginning of the presentation have been followed. The only difference is that we try to get advantage of the concept of inserting the abutment only once, in this particular case only twice. So going to the conclusion of this short presentation, my messages, most important messages of this time spent together is that before starting a case that is treating an implant, especially on the aesthetic zone, we have to identify the proper three-dimensional implant position. And if you want to make some mistakes, or if you want to play safe or safer, we prefer to have the implant placed a little bit deeper and a little bit more palatal than what we are expecting. The second step is that Luca definitely showed properly previously. We want to work on a good surgical environment. It means that we want to hyper-correct hard tissue and especially soft tissue. And finally, we want to have an adequate prosthetic profile in terms of shape, especially with an under contour profile on the facial aspect and a more straight profile on the interproximal and palatal aspect. And materials can also help us, but definitely are not what is making the difference. And the last message is that we want to spend time in diagnosis. Diagnosis is always important. Planning of the case before starting, identify the biological timeline and the prosthetic steps that we want to do is probably the most important aspect that we want to do before starting the case. And with this slide I arrive to my conclusion. I hope you enjoyed this time spent together, and I'll see you in the next presentation.